Hi, good morning. I'm Lisa Kuwald and I was the patient representative on the cardiac working party, and I have a son, Felix, who has Duchenne. So I just very briefly wanted to, just very briefly from the patient perspective of the cardiac guidelines and why they're so important to patients of these guidelines to be made. And again, from the survey that Alex spoke about earlier, this was a slide that just showed I think 24% of patients don't always have a cardiac appointment every year, and 12% from the survey have never had a cardiac appointment. And again, from the survey, approximately 20% haven't had an echo or ECG every year, and 82% have never had an MRI. And I think coming from the survey with patients, having the MRI as well is something that seems to be quite important to them. Oh, sorry. Yeah, and these were just a couple of comments that have come from actual patients about their worries and concerns with the cardiac care. So again, I think a lot of it comes from feeling like they can't access care early enough. So for example, here, I had to go to another hospital for a prescription. I've gone to appointments armed with a file of evidence to state my case. And I think that comes back from what Emily said about having giving papers out on perindopril, and lots of patients have used those when the boys were younger. Having to fight for something else that is so important is exhausting. And I felt like I had to beg for my son to have heart meds when he was younger. So it's all similar themes. I came away frustrated and feeling like a diagnosis when we were told to enjoy our boy. So just some of the concerns from the patients. And again, this just gives a quick conclusion from the survey. So access to a dedicated consultant cardiologist from the early age and into adulthood. Having those annual checks, the echo, ECG, and then sometimes MRIs. Having the choice to start the heart meds before the age of 10. The heart meds to include, as appropriate, ACE, MRI blocker and beta blocker. The management of heart failure was another thing that they were concerned about. And again, improved monitoring for female carriers and also for adults. That was something else that was coming from the survey. But I think obviously now the guidelines have been published, and the main conclusion from the actual guidelines is here, and I think it just sort of summarizes why they are really so important from the patient perspective. And they say it's now widely accepted that the late initiation or overcautious use of cardioprotective medications in children leads to lost opportunities. So to mitigate the cardiac effects of the condition, which cannot be compensated for even by optimized cardiac management later in adulthood, and preserving that cardiac function is a prerequisite for longer survival. And so this guidance is intended to contribute to that goal more consistently across the UK. So from the patient perspective, I really do think that conclusion in the guidelines says it all, and why they're so important to us. But John's going to go through everything with you, and I think, is he online?
Thanks, Lisa. Yes, I'm online, and I'm relying on you to advance my slides for me, if you wouldn't mind. Yeah. I hope you can hear me all right. Okay, so if you just move on to the next one then. Kathy asked me to include in what I was saying a little bit about emergency care, because it was part of overlap with the cardiac working group. I know there's a presentation later on the app itself, so I just wanted to say a few words about the importance of the emergency care information, both for clinicians and for patients and families. For example, most of the doctors that families and patients will encounter, for example, in A&E, or in the community will not be familiar with Duchenne at all, and therefore won't be aware of the specific concerns. So having readily accessible information that they can, if you like, log into or can be directed to or pointed to by the families is really critical in some contexts. If you just advance there, Louise. So, for example, you may never need any of this advice, but for families, it's very important that if they do have to attend A&E particularly, or they're in an emergency context, or they're away from home or something, the app obviously provides individual patient information, but the online information is actually to have something that first responders, if you like, can access to tell them about some of the specific concerns. So it's to provide up-to-date clinical information, particularly to A&E staff who are a hard-to-reach group very often, and it deals with the specific aspects that are relevant in an emergency for a patient with DMD, regardless of the age they're at. If you just advance again, Louise. So this is just a screenshot of what would be presented online to just logging into Google and looking for the Duchenne A&E pack. And if we just click on one of those, if you just advance, Louise, one more, if you look at the cardiovascular one, it sort of lists some of the things that are relevant in routine care, hypertension management, what to do, what not to do. If the patient has a persistent tachycardia, that would be more in the community or just on a longer term basis, or something that might puzzle a GP, for example. And then in hospital, there's some other aspects that would be more relevant in the immediate term for somebody who's critically unwell. And if you click again, Louise, this then is backed up by references which come with the pack, if you like, that somebody needs to have a look at these later or is wondering what the evidence is for what we're doing. So I'm not going to say any more about the emergency pack or indeed the emergency app, because you'll hear more about that later on. So for the rest of the time, I want to focus on the cardiac aspects specifically. If you can advance there, Louise, again. So the manuscript that's now been published and is readily available online, which I'll show you in a moment, actually takes you through what we're actually recommending and says a bit more about it. But just as by way of background, you're all familiar that there are various different kinds of muscle in the body. If you click on again, Louise. And the important point we've been trying to get across is that the heart is involved in Duchenne from the very beginning. It's not a separate diagnosis, it's not a separate disease, it's the same Duchenne condition that the patient and the family have been told about from other healthcare providers prior to ever seeing a cardiologist. If you click on again, Louise. And essentially the effect of Duchenne on the heart, we're primarily interested in the weakening, the progressive weakening of left ventricular function. That's essentially what we're talking about. If you click on again, Louise. So essentially, if to move it away from molecular biology and look at it in more simple terms, the cells, the myocardial cells, just like skeletal muscle cells, are uniquely damage prone as a result of the Duchenne process. If you click on again, Louise. So if you think about this analogy of a deck of cards, the normal beating activity of the heart day to day in a Duchenne boy leads to damage and a need for excessive repair and swamping of the repair mechanisms over time. And if you click on again. So it's not a question, as perhaps was thought years ago, that will this boy develop a cardiomyopathy? It happens in all boys with Duchenne. And so the question then centers around what's the optimum time to start heart medications to, if you like, modify this innate process that's part of the condition. If you click on again, Louise. So you're all familiar, I'm sure, with the fact that there's international care standards which have been published, and the obvious question was, why do you need UK specific ones? Well, there was a general feeling that the international care standards covered everything, but there was perhaps too much wiggle room. And we felt that that was leading to a kind of postcode lottery about what treatments were being available, how much patients had to press for them, and what families were actually receiving, therefore was discrepant across the country. If you move on again. So again, Kathy has described previously, and so has Gerard, how the guidance were arrived at. It was a consensus plus evidence amalgamation, then circulating of the expert and guidance extracts to a wider group than the original core group, if you like, and then a consensus reached about what should be included and with what emphasis. So if you move on there, Louise. So it resulted in this, as I mentioned earlier, this open heart publication, which was originally designed to be a flow diagram with references and nothing more. But it became quite clear in the course of the work that we needed to explain some of the bits of it for it to be understandable, and also to broaden out in light of some of the early critiques we'd had of earlier versions. If you click on again. So again, it is available to download for families, for patients, for clinicians of all specialties and subspecialties. If you click on again. And essentially this diagram, which is in the publication, summarizes the core message. It says, as you'll see there in the top left-hand corner, regular heart checks should start as soon as convenient, and certainly before the age of 6. So what do we mean by that? We're trying to get a baseline assessment of heart function, typically by echo and ECG, against which to compare changes that are likely to occur in the future and which we're trying to modify. We also stress the fact that steroids, despite what some animal models have shown, that steroid therapy is beneficial for the heart also. So essentially, a boy has started on this cardiac surveillance program from an early age and is moving down the right-hand side of this chart. There's no heart weakness on echo. The ECG may or may not be abnormal, but you have a relevant record of heart rate. The heart is normal, it's being checked annually from the age of 10 and possibly at the same frequency even prior to that. If left ventricular function by echo becomes abnormal at any stage, you move to the red side of the diagram. That's the left-hand side, which we'll talk about in a moment. But as you approach the age of 10, and if the boy isn't already on heart protective medications for prophylactic reasons, then you need to start them at that stage. If you're not going to start them, then you definitely need a magnetic resonance scan of heart to show whether there's fibrosis developing, which would also be a justification for treatment at that stage. Obviously, some people will use MRI scanning as part of earlier surveillance, but you're probably not going to administer the parts of the scan, the MRI scan, which would show fibrosis every time you do a scan if you're doing it more often. So let's say, for the sake of argument, the family want to start treatment prophylactically after discussion, which can happen at any age, or the patient has manifest some early signs, the earliest signs on tissue Doppler, for example, or global longitudinal strain of echo abnormality. You start an ACE inhibitor in a recommended dose for the boy's size and weight. If for any reason the ACE inhibitor is not tolerated, which occurs in about 10% of people, then you switch to an angiotensin receptor blocker, which achieves pretty much the same benefits. And the effect is generic, as far as we know, for any of the particular medications. Most of the boys, by the time they're showing heart abnormality, and possibly even ahead of time, will show a persistently abnormal heart rate, excessively fast. So part of your management here, if that is the case, is to add a rate-slowing medication, a beta blocker. There are rare occasions when somebody can't have a beta blocker or won't tolerate larger doses, in which case there is an alternative agent or a supplementary agent, ivabradine, which can be used to slow the heart rate without beta blocker adverse effects. And finally, when you've optimized the doses of medication, which is important, you don't want to leave a boy who's growing and moving into adolescence on a dose that was the starting dose if they justify a larger dose. You then add an antifibrosis agent, that's a eplerenone or spironolactone. So if you show the next slide then, Louise. So essentially, all of the boys progressively are established on appropriate doses of a 3-drug regime, which is ACE inhibitor, beta blocker, mineralocorticoid receptor antagonist. And of course, you need checks to check on renal function, check on blood pressure, check on heart rate, check for potassium levels, that they don't rise abnormally. But in general terms, these medicines are very well tolerated. They don't cause problems that would justify any delay in starting them. And normally, they're not onerous to take or to comply with. If you just show us the next one. There is an important caveat here, and it often causes confusion for families. And that is that if a boy is admitted, say, with a pneumonia in the context of Duchenne, they'll often be told in the course of that illness, oh, blood pressure is very low, we need to stop these treatments, they're working against him, and so on. That is true if somebody is critically ill, blood pressure may be abnormally low. The ACE inhibitor, for example, may have to be withdrawn temporarily or the dose reduced. But that should not be interpreted as meaning that these medicines are contraindicated for the future. They should be restarted as soon as recovery allows, working back to the previous doses. And that's an important message to clarify if you're stopping these medications, that this is a temporary stoppage, not a permanent contraindication. If you show us the next one, Louise. Now, as Louise has already said, the effects of treatment are critically time dependent. So if you click on to the next one, Louise, you can't compensate by over-treatment or starting treatments inordinately late. That won't compensate for what damage has already been done, and you may have missed the opportunity, exactly as Louise has said. If you show us the next one. So that's all I want to say about Duchenne boys and the heart management and the prophylactic elements, the testing elements, and the treatment elements. I want to say a bit now about female carriers who tend to be a neglected group from the cardiac point of view. If you show us the next one. So this tries to summarize what we're recommending for the carriers, and this is also covered in that publication. When a female is confirmed to be a carrier of the DMD gene, part of that conversation with the genetics test result discussions should be to point out that they need cardiac surveillance for the development of cardiomyopathy. This will only affect a small minority of the total, but it's very important not to miss a developing cardiomyopathy. So, for example, you would hope that patients never enter this flow diagram from the red symptomatic box, and yet we see this possibly every few years, a woman coming to transplantation or something who there was reason to have them tested previously as well, but it perhaps never happened, or they never knew that they needed heart checks. Once the diagnosis is made, as soon as convenient, they should have a cardiac baseline assessment, which typically involves an echo and ECG, but it also involves a discussion of the rationale for heart testing, why they're being tested, but also what the effect of finding an abnormal result would be. And that helps them understand and makes it worth their while, if you like, continuing with surveillance. You then do your tests, that's the echo and the ECG. Increasingly, an MRI test is easier to justify in this group of patients than it is perhaps in Duchenne-affected boys, particularly at the younger ages. The test will either be normal, that is the echo test, abnormal, equivocal, or abnormal. If the test, that's the echo test, is equivocal, then you need an MRI scan to clarify the situation. If it's abnormal, then you start treatment. If you click on the next one, the frequency of testing, if it's done by echo, should probably be every 3 years, repeated. If it's done by MRI, you may be able to stretch out the interval to 5 years, assuming, of course, that everything was normal at the previous check. But critically important for cardiologists, for pretty well all healthcare professionals involved in this, and for the patients, is that a normal initial assessment at any point does not confirm that you won't develop a cardiomyopathy later on. So you need to maintain surveillance despite an initial and subsequent normal tests. And if you show us the next one, Louise. And essentially cardiac management of women carrying the gene for Duchenne is the same as for males with Becker muscular dystrophy, which in turn is the same at the moment, same generic treatments as for boys with Duchenne. And if you show us the next one. So essentially, to summarize the cardiac situation, the heart is abnormal from the very beginning in Duchenne. If untreated, heart pump function weakens progressively over time. Symptoms have nothing to do with it. They emerge when your heart function is at rock bottom and you're going into heart failure. Regular heart checks, therefore, are needed to show and to allow titration and adjustment of your heart regime. Steroid therapy has a beneficial effect for the heart. Importantly, the heart medications we've talked about are well tolerated. Heart medications do not replace dystrophin, and so the best we can hope for them is that they slow the natural progression that would happen otherwise, and preserving heart function, as Lisa has already said, is essential to long-term survival. If you show us the next one, Louise. So I want to acknowledge the people who played a critical part, both in funding, making possible, and also contributing to the review. And if you move on to the next one. These are both the adult and the pediatric, both are published guidance, and you can read all about it at that stage. Gerard has also talked about what the next stage are. Obviously, publication is base camp, if you like. It's the implementation that's critical. Within the pediatric guidance, we have suggested an audit tool which units can apply in their own unit to assess how they're doing against the standards. Obviously, that tool could be used to compare centres. And Ros Quinlivan spoke yesterday about a process that's underway for accreditation of Duchenne sites, which we think will help implement all of the guidance of the various aspects of Duchenne. But I think audits are the way forward, in addition to the obvious presentations and sort of webinars we can create for this. So I'll stop there and take any questions. Thanks very much.